Thank you all for attending and welcome to the FOV supporters meeting. This is the second year in succession that we've had this online. As you know, the pandemic has been completely thrown everybody's plans into disarray, and FOV is no exception. But we're lucky that we've managed to find alternative ways to do things. And so we'd like to start this meeting with a word of prayer. I welcome Thoman to open this meeting with a prayer. Thoman, over to you.
Thank you. I'm going to start by reading from Psalm 63, verses 1 to 9, and then move on to pray. So let's pray. O God, you are my God. Eagerly I seek you. My soul is athirst for you. My flesh also faints for you, as in a dry and thirsty land where there is no water. So would I gaze upon you in your holy place, that I might behold your power and your glory. Your loving kindness is better than life itself, and so my lips shall praise you. I will bless you as long as I live and lift up my hands in your name. My soul shall be satisfied as with marrow and fatness, and my mouth shall praise you with joyful lips. My soul clings to you. Your right hand shall hold me fast. We are gathered here as one, as your children across the globe. We ask for your presence among us as we discuss matters relating to CMC Vellore and its work. We praise you for the work that CMC Vellore has done over the last century and more to progress your kingdom on earth, for the lives that have been served and touched over the years. For those who were there in the beginning and after, serving you and ministering to those who need it, for those who are there now, and those who are to come. We pray for the medical college, for the various hospital campuses and the work done by the staff and leadership within the institution, for the rapid growth seen in the last few years as the community in Vellore serve more and more people in different campuses and across the country. For the community health department and its various projects, for RUSA, the town work, for CHAD, and in particular today, the Jawadhi Hills project. We thank you for this opportunity to be able to listen to JV Peter, the director, and Anu Rose, who's running the project in the Jawadhi Hills, as they present their work today. We would also like to remember especially Brian Witchells, who is a Friends of Vellore supporter and who has served you faithfully in Vellore for a number of decades and continued to do so even after his retirement. We pray, Lord, that you would be with him as he is admitted in hospital and is unwell, and that you would be with Anne and Nigel and Jeremy and the family as they are concerned about his health. We thank you, Lord, for his service and what he has done in the past. And we ask that you will be with him and that your spirit will blanket him with your presence. We ask all these things in your name. Amen.
Amen. Thank you, Thoman. And as a welcome to this meeting, I'd just like to thank all our supporters for a project that has consumed a lot of us. The last 6 months, we spent a lot of our time and efforts raising funds for the pandemic, for the second wave. Special thanks to Thoman and Johnson, who are both chest physicians here, who helped us in guiding us in how we help various, both Vellore and other mission hospitals in India. We've managed to raise £220,000. And in addition to helping our parent institution, Vellore, we also have been fortunate in that we've been able to help smaller mission hospitals. And we will now, Ruth will give us more details. The slide that I had was a picture that was shown in the Pulse a few weeks ago. And it shows a 10-year-old boy called Raju. Names have been changed, obviously, for identity reasons. And Raju was a 10-year-old boy who lives not far from Vellore. His father is a load carrier at the Vellore main vegetable market. And for those who are unfamiliar with the load carrier, it's what we in the UK would call a porter, who spends the day carrying sack loads of vegetables from the truck to the main vegetable market and earns about 300 to 400 rupees a day, which translated to pounds is about 3 to 4 pounds a day in the best situation. Now, with the pandemic, obviously, he didn't have work. Raju lives with his father, mother, who's now 9 months pregnant, and his 8-year-old sister in a house which consists of a single room, an asbestos roof with a hole on top, which serves as its light, and no toilet in the house.
Alan, you can share it now if you'd like.
Thank you. Can you see the screen now, Ruth?
No.
Okay.
At the bottom of your, yeah, something's coming up, the island.
Okay.
We can see it.
You can see the slide now?
Yeah.
Okay. Sorry about the technical glitches. But yes, so that in your picture is Raju, the 10-year-old boy. His father, Kannan, who's a coolie, as what we call in India. And interestingly, that's not his mother, that's his aunt, his father's sister. Mother couldn't be in hospital because of COVID reasons, and she was pregnant, so she couldn't come in. Now, Raju, obviously extremely poor, extremely marginalized, extremely vulnerable, lives very close to the main hospital. He was brought to LCECU with breathing difficulty and in shock. After tests, a diagnosis of a multi-system inflammatory syndrome in children secondary to COVID was made. He had acute respiratory distress syndrome, hypovolemic shock, myocarditis, pancreatitis, which means that 4 of his organs were affected, and he was admitted to the pediatric ICU. He needed non-invasive ventilation, inotropes, steroid pulse therapy, intravenous immunoglobulins. All of this was provided to him. He improved in ICU. After a few days, was moved to HDU, and then a few days later, moved to the ward, and 3 weeks later, was sent home well. And this is the picture of him before he went home, a happy boy, well, and looking forward to normal life. His bill came up to 5,70,000, which converted to pounds is 5,700 pounds, which translating into what his father earned, his father would have had to work for 5 years without saving anything and paying all his wages to be able to pay the bill. Obviously, he couldn't do that. His father borrowed money and paid 15,000 rupees towards his bill, which is 3% of the bill. The remaining 97% was written off, thanks to donors like yourselves and others across the world. Because of all of this, and because of CMC, this 10-year-old boy is alive and well. To me, this epitomizes what the institution is all about. When Aunt Ida set up the institution, it has now moved on to a center of excellence. We are all aware that some of our leaders, Dr. J.V. Peter, Dr. Gagandeep Kang, Dr. Priya Abraham, are all on the national forefront leading the fight against the pandemic. But what Aunt Ida would be really proud of, in addition to all of that, is that Raju wasn't forgotten. Thanks to all of you, all the donors in UK, and many other donors across the world. And we hope that we will continue to help in helping many other poor patients marginalized patients, unfortunate patients like Raju going forward. We now move on to our next part of the program. We're very fortunate to have JVP and Anu Rose with us. Dr. Peter, I hope you don't mind me referring to you as JVP. I go back to my college days when we were college mates together in Lazarus House, spent many, many hours practicing for inter-house music competitions, but you will always be JVP. So we're very fortunate to have JVP with us. I think the whole administration in Vellore needs to be commended in the way this pandemic has been handled, led by JVP. JVP is at the moment in Bangalore attending another meeting. He's just finished that and has agreed to be with us for just a few minutes. He's going to give us our presentation and have to then leave. So over to JVP. Thank you very much, JVP. And we're looking forward to how things have been in Vellore.
Thank you so much, Dylan and Ruth, Thoman, and all the friends in the UK. Even though we are so close to the situation and have experienced many such instances when Dylan narrated the story, my eyes were whelmed. Oh, and that sort of expresses my sentiment. I hope I'm able to speak well despite that. I have made a small presentation and I'll try to stick within the time frame that has been allotted to me. Is my screen visible?
Yep, we can see you, JVP.
Okay, I'll start with a brief overview for those who have not known much about CMC. I'll speak about the year of COVID, brief project update, and some concluding remarks. As you all know, CMC is a fairly old institution by Indian standards, 121 years old, with a 102-year history in medical education and founded by the American missionary Dr. Ida Scudder. It has a very clear vision statement to be a witness to the healing ministry of Christ through excellence in education, service, and outreach. We did celebrate Aunt Ida's 150th birth anniversary last year, and many of you from the Friends of Vellore UK participated in these events. The key components of the institution are education, service, and research. The entire spectrum of education, medical, nursing, and allied health are provided. We look after a wide range of clinical services and are involved in a fair amount of research, which I'll touch on. We also do a lot of outreach programs. The college campus is as beautiful as ever, thanks to the efforts of several people, including Dr. Thomas Kurikos's wife, who happens to be in charge of this. We've also been blessed with abundant rains over the last 2 years, very much unlike usual times. We have been blessed to be ranked the second best medical college in the country by most of the media houses like India Today and The Week. But the government itself has ranked us third, and the information for this year was released a couple of days back. We're very grateful to God and to the people who have gone before us, whose efforts we are reaping now. The main service component happens in these campuses. The main campus, which has 2,400 beds. The Chittoor campus, which is very vibrant, has 130 beds. And the new campus in Kanigapuram, which we expect to be commissioned in January 2022. As you're aware, there are many peripheral campuses doing rehabilitation, ophthalmology, mental health, and several community outreach programs. And the Friends of Vellore UK support a wide range of projects, particularly in the outreach areas. There is overwhelming support from you all for the tribal outreach work at Jawadhi, and Anu will speak a bit more about it. I'll go on to the next activity of the institution, which is research. We do have 2 core research facilities, the Williams Research Building and the Stem Cell Research Center. And we hope to have another facility in Kanigapuram, and some seed fund has already been received. We had a record number of IRB submissions in the last year, despite the COVID, 1,485 IRB submissions. About £1 million was granted as research grants from within CMC. And I'm very pleased to report to you that external grants have only continued to increase through the years. It's about £5.5 million in Indian grants and about 9.5 million of overseas These are all only research grants. So there is a lot of research that is happening in CMC, about 800 publications a year. The first wave of the COVID in India happened between June and September 2020. It was a steep learning curve. We ramped up beds to be able to have about 910 beds at the peak of the first wave. And this was more an exercise of God preparing for the second onslaught. And the first wave really literally paled into insignificance. In the first wave, we had done about 55,000 tests, a high positivity rate because of the referral nature of the organization. We had treated about 10,000 patients with a peak of 100 admissions per day and a mortality rate of 5%. There was a lot of training and capacity building during the first wave of the pandemic when we were very generously supported by several donors in doing some training programs, reaching out to doctors and nurses in mission hospitals and government setups, as well as training frontline COVID workers. Over 200 research projects related to COVID have been submitted over the last year. We are again very thankful to God for the recognition of CMC in several fronts in workplace safety, hospital preparedness, and charity hospital. And we are also grateful that many of our faculty are part of both state and national task forces guiding the government as to the strategy or approach of COVID. The second wave was expected, but it came much later than we expected with more intensity, and patients were much sicker, needing more oxygen, and much younger, and we had to rethink strategies. At the peak of the second wave, we had to have 1,150 beds. Our ICUs were overwhelmed. We had 105 level 3 ICU beds, and we soon realized that we needed to open up more ICU beds. So level 2 units were converted into ICU facilities where about 250 patients in addition were non-invasively ventilated, a very high number. We also looked after a home-based isolation program, a monitored program, which is a great success. During the 2 months of the second wave of the pandemic, about 2,000 patients were monitored at home and managed by nurses. It was an extremely successful program in that the failure rate was only 6.5%. And amongst the 2,000 patients who were monitored at home and treated, only 0.4% passed on. So the stress on the health system is greatly reduced. This publication has been written up, and we hope that this will transform our approach to another wave if it happens. As of last week, we have tested over 90,000 samples, and the positivity rate is still quite high. This is a graph which shows you the bed allocation during the two waves. It had come down to about 100 beds last week, and we're down to 50 beds. Now we have only 30 inpatients at the moment with COVID. The weekly positives, these are the two waves. As I said, the first wave literally paled into insignificance compared to the second wave, where we had 1,852 positives in a single week. At the moment, we have about 70 to 80 positive patients in a week. We were very fortunate to have a team of epidemiologists who were able to give us weekly projections for the district as well as the state. And we were involved very closely with the local planning district team as well as the state and these projections are extremely useful and quite accurate. As I said, the home isolation program was a great success during the second wave of the pandemic. So far, we have had 15,870 admissions and an overall mortality of 9.5%. During the pandemic, we realized that CMC had several areas of susceptibility, and we went ahead thinking through how we approach these areas of susceptibility. There were 4 domains that we looked at: infection risk and the third wave, supply of essential medications and other drugs, financial susceptibility, and psychosocial. We realized that about 25% of our healthcare workers were affected during the 2 waves, but we also have some work which was done in our institution, which suggests that the reinfection rates are extremely low in our cohort of patients, healthcare workers, and it's estimated to be about 0.5%. Over 95% of our healthcare workers have been vaccinated, and our CMC healthcare worker protection status for vaccination has been published in the Mayo Clinic proceedings, and we found that 2 doses of vaccine offer about 65% protection against infection. We are not quite sure about new strains and virulence. but we think the risk is probably quite low unless there are new mutations that come in the horizon. Um, However, we are continuing to ensure there is emphasis on infection prevention control measures. As I said, the third wave depends on the susceptible population, and we are participating with the government in an aggressive vaccination program. We have started a program called Vaccinate Vellore campaign, and we've raised substantial amount of funds for this. We have a vaccine bus. Hopefully, it will come in the next week, and even the remote villages are being systematically approached through our peripheral community programs. Tomorrow, the government has initiated a huge vaccination campaign. The Vellore District Administration has asked for, initially they asked for 300 nurses, and just now I heard the information that they want 700 nurses from CMC to participate in this vaccine program, and we have been able to depute about 500 nurses for this program. We are doing a lot of charitable vaccination, particularly to the susceptible population through our community outreach. And this is the number that we have vaccinated through the program. This is in addition to the other vaccination that happens in the hospital, where we have done about close to 30,000 vaccinations. Pediatric population, we understand, could be susceptible. We don't have vaccination for children, but we have done a lot of work in preparing for the pediatric population in case that occurs. The second domain of susceptibility is medical equipment and drugs, and we had some problems both during the first wave and the second wave in procuring a lot of equipment and drugs. We had very generous donors from across the globe, including friends from UK who gave us donations in cash and kind, and we are now looking at equipment needs in children. These are some of the examples of some of the equipment that we were able to procure through the generosity of donors, ventilators to HFNOs, and even pillows and mattresses were donated by people. We were overwhelmed with the number of oxygen concentrators that we received, and we have been able to pass on this gift to other people. And by God's grace, we were also able to bail out the government hospital twice when they ran out of oxygen, and that prevented a lot of deaths. And that also enabled us to have a better rapport with the local administration. We have also been blessed abundantly with four oxygen concentrator plants. One came through the French consulate, which also has a bottling plant. The other came through the Asim Premji Foundation. One came through the Questcop Fairfax partnership. One through Trimalai Chemicals, and another unit from our friends in the US. So we have implemented a 10% oxygen subsidy for our patients, given that we were able to procure these, and these came in very handy during the second wave of the pandemic. You may have heard that there were in the media that there was a lot of oxygen shortage. By God's grace, we were able to manage because a lot of measures were taken earlier to mitigate this risk. Susceptibilities of medications, we were not really very much affected because we had planned well in ahead and had stocked enough medications, so we never really ran out of medications. The next susceptibility is finances. Our income reduced dramatically during the first wave and reduced substantially in the second wave. They are improving. They have not yet reached an optimal point, and our fundraising efforts continue to bridge this gap. The revenue shortfall in the first wave was huge, 350 crores. I don't know how much it translates to. It probably translates to 70 million pounds. And the second wave, it translates to about 20 million pounds. That's the revenue shortfall, but by God's grace, we are able to stay afloat. This is the fundraising effort through various partners, and even the staff pitched in to give about more than £1 million as a donation, not as a salary deferment, but as donation for COVID work. And this is a graphical representation of how the fundraising effort has really helped bridge the gap in our institution. And I want to place on record our gratitude to you all for having dug deep into your pockets to help tide through the crisis. The next aspect of susceptibility is psychosocial impact. And as you know, community living has been a high point in CMC, and that has been really affected. And we have put in a lot of effort to try and keep the emotional and mental well-being of the community through several activities and programs. I want to briefly touch on post-pandemic. Where are we headed? We need to recalibrate, and we're looking at different strategies. We want to be progressive, we want to be optimistic and proactive, and continue to be relevant. So we've gone back to the basics and looked at what is our foundational vision and vision. All have come out of a response to a call, but we need to respond also to changing needs, and we are looking at service above self, which has been the way CMC has always functioned. And in all this, we want to keep the core value intact as we dream ahead. We are dreaming ahead in the field of education. We are working on the simulation and skill-based training program, which is a centenary project, which has been generously supported by a couple of ASHA grants and other grants from others. Several new courses have been started, including DM in virology, which happened in the year of the pandemic, pediatric orthopedics, neuroanesthesia, uh, and one more, I can't get it, but we have more courses in the pipeline. We are thinking of new technologies, robotics, hybrid theaters, high-end cancer services, trauma, level 1 trauma, pediatric specialization, cyclotron, digital pathology, and a whole lot of outreach programs also. As Thailand very aptly put it, we cannot forget the poor amongst us. If we do, we have lost our soul. Research, we are a treasure house for research, and as I said, we are planning for a research block at Kanikapuram. Very quickly on the projects, the old student nurses hostel has been refurbished, was commissioned for use during the COVID in May 2021. It's now fully functional with orthopedics utilizing this facility. There's 11 operating theaters, ICU, wards, and some support services. Chittor is vibrant. The working women's hostel that you see on the right is almost ready, and it will be commissioned probably next month. It's been slightly delayed. They have also had a radiology suite put in there in the last year and has a CT scan there. And as I said, the Kanigapuram project is a bit delayed still. We hope that the whole project will be completed by Jan 2022. However, we use this Kanigapuram facility for COVID too, and we got the ICU there. Operational record time, 36 ICU beds were operationalized, and almost the entire equipment came through gifts from various well-wishers. Kanikapuram housing, a little more left to be finished. We hope it will be done in the next couple of months. So I want to conclude by saying I believe that the worst is behind us. I want to thank you all for your support. A lot of you have prayed for us and sent in very encouraging messages, mails. Many have given us inputs, and I'm sure that we will come through this victoriously because God is our helper. Thank you, and God bless.
Thank you very much, JVP. To anyone who wants to ask any questions, there's a box. There will be at the bottom of your screen, there will be a Q&A. So if you can just type in your question, the panelists here will be able to look at the question, and then we'll put it forward to JVP. Thanks so much, JVP. We really appreciate your time and your busy schedule. Can I just kick off the questions by asking, one of the problems we've had both in the first wave and the second wave in the UK and the NHS is staff being affected by the pandemic. So in the first wave, the main problem was pandemic, where actually doctors, nurses, and workers came down with the virus and got affected by that. And the second wave, in addition to the pandemic, we had something called the pingdemic, where everyone was being pinged to isolate. And so most staff were being unable to come to work. Was that a problem in Vellore, and did it affect your work?
Not really, in the sense, right from the beginning, staff protection was our priority. So we spent about 3 crores of rupees, that is about 600,000 pounds a month for PPE. So people did come down with COVID, but not very severely. And the vaccination program is very aggressive. And by God's grace, we have lost just 2 staff due to COVID out of about 12,000 staff. So this has not been a big problem, and we have been able to manage with all the leave and things like that. We have used both Covishield and Covaxin. We are following the 12-week interval between doses.
Yeah. Okay, thanks. Question from Prema. Is CMC planning to have permanent oxygen supply unit, considering the possibility of COVID being an epidemic rather than just a pandemic?
we have looked at oxygen. Uh, that's what I said. No, we are looking at susceptibilities and how we can bridge those susceptibilities. And water, power, oxygen, medications. We have identified quite a few domains. During the peak of the pandemic, with the concentrators that we have, we could only manage about 30 to 40% of the total oxygen requirement. Uh, the challenge with using concentrators is that it doesn't give us 100% oxygen. And so we have problems running the ventilators and other things. So we are still not independent of an external source. But at the moment, our oxygen requirements are down from 6,000 to 7,000 cubic meters to about 3,000 a day.
Okay.
I hope I've
Yeah.
answered that question.
Yeah. One of the things that sort of we feel, apart from we've been quite active in raising money, but also prayer support. Going forward, we have the Maitri bulletin that comes out. Is there any other way we can improve or channel the prayer support that we can offer? Uh, this is maybe a question difficult to answer off the hoof, but going forward, in addition to being just helping monetarily, we also need to be helping in other aspects, and prayer being one of the major aspects. Any ideas or any thoughts on that, JVP?
See, I'm of the firm belief that people across the world have been praying for CMC, and when there have been specific needs, prayer requests, we have passed on those to our friends who have prayed specifically for those. So I think there is a good mechanism in place, and I think that should be sufficient.
Okay, yeah, no. And then just one more question from my point of view. This has been a huge financial hit on the institution. I mean, stopping all elective work for such a long period of time, hitting the finances. In a nutshell, how long do you think it's going to get CMC back on course to where we were before the pandemic started financially, to be able to then get back to even keel?
See, I think God works in very mysterious ways. When we recruited our general superintendent and treasurer, we went out of the norm in choosing two people who are not inbred people, two people from outside. And both were extremely useful during the pandemic. One had came in with skills with buildings and planning and got an ICU ready in 2 weeks. The finance person worked in Cochin Metro and he had such a deep knowledge on financial management. So we brought in a lot of fiscal discipline into the system, and we realized that a lot of tightening had to happen in several domains of spending, which we put in place. Despite all this, in the last financial year, for our operational expenditure, we were able to meet the entire operational expenditure through our revenue. Of course, we had a lot of projects happening, so we had to borrow for that. This year also, God willing, we think we'll be able to meet our operational expenditure. So the short answer is, it is going to take some time because of a huge debt burden for the project. If the project wasn't there, we should probably break even in a year or so, get back to normal. But the project debt will take about 10 years to repay.
Okay, thank you for that. One last question before we wind up this part of the meeting is Regina and Jed have asked, I think you alluded to this before, but probably didn't make it clear as to what are the vaccines that are being used in India in the vaccination program.
So at the moment, the Covishield is the AstraZeneca Oxford vaccine that is manufactured in India, and that is the one which comprises the bulk of vaccination. Roughly about 90% of the vaccination is with that. The second vaccine is Covaxin, which is indigenously developed. It has similar, if not slightly more, it's more broad in the sense of antibody response, and even the protective effect seems to be as good, if not slightly better than Covishield. The other vaccines, the Sputnik is in India, and Anu's husband is involved in some trials on Sputnik vaccine. The Johnson vaccine, I think they've given the permissions. We are working very closely with the government through the task force, Supreme Court task force. And I'm very pleased to report that we have hit in India 10 million vaccination doses a day on a good day, and about 7 million on a not so good day. So I think the vaccination program is going pretty well. I also need to point out here that the seroprevalence studies that were done, by the Indian Council of Medical Research suggests that about 65 to 70% of the population are already seroconverted. So that is why we think a combination of vaccination plus prior infection would not result in a huge wave unless there are new mutants or vaccine breakthrough or all those fancy things that people speak about in pandemics.
Great. Thank you very much, Dr. Peter, and thank you for your time. Safe journeys back to Vellore, and wish you all the very best. Our thoughts and prayers are with you.
Thank you so
all
much.
the best. Thank you so much.
Thank you. Thank you for this opportunity. Thank you and God bless.
Okay, we move on to our next speaker now. Anu is going to talk to us. So those who are unfamiliar, Anu works at CHAD in Bagayam and is in charge of the Jawadhi Hills project. Jawadhi Hills was just a name to me when I was in Vellore as a student. I'd heard of it, but didn't know anything about it. But CHAD has taken that whole area up and has been doing a lot of work there. Anu's going to give us an update on that and how we as FOV UK can help further in their plans that they have for Jawadhi Hills going forward. So over to you, Anu. Thank you very much.
Thank you, Dr. Dayalan, and good afternoon, everybody, and thank you for giving me this opportunity to share my department's work. Ruth, am I audible?
Yep.
Okay, thanks. So I want to start off by saying that a lot of work in Jawadhi has been possible thanks to the various FOVs and FOV UK. And let me start by thanking you for your prayers, for your support for our work in Jawadhi. So again, I'll give a quick brief introduction in keeping in mind that I have 20 minutes, but this is where Jawadhi is. Vellore is here. This green area is Jawadhi, and it's a part of Tamil Nadu, in the northern part of Tamil Nadu, not very far from Chennai. And there are some of you on today's meeting who have visited this area. So I want to start off by just telling you about three stories of three women who died during their pregnancy and delivery. And all three have very unique situations, because generally when we talk about Jawadhi, we talk about poor geographic access to healthcare. And we found that it's always not just the access to healthcare which is causing women to die or for us to have maternal death. So very quickly, this is in a village called Periyatattankotai, and this is a young lady, 21 years old, called Tamila, who had a home delivery because she could not reach the hospital. Her house is in a place which doesn't have road access. So she delivered at home. She had a retained placenta, and she bled a lot. And by the time it was daybreak and they could actually take her to a place where there was cell phone coverage, she actually died. A place where there was no geographic access to healthcare, because there was no phone coverage for them to call for the ambulance, nor was there a road for the ambulance to reach. The second person I want to talk about is this lady from a village called Vallikottai, which is just 2 kilometers away from the main PHC, the main primary health center in Jamnamattu. That is the biggest town in Jawadhi. This lady, unfortunately, was a migrant laborer. That is, she is a tribal lady from Jawadhi, but she had migrated for labor, therefore had not registered for antenatal care in Jawadhi. So when she went for antenatal, went in labor, she was referred to another PHC, which was 20 kilometers away. And from there, referred to another PHC, which is 35 kilometers away. By the time she reached, she was quite sick, and she died after a cesarean section. Her baby is now 3 years old. And this lady who I want to talk about was actually registered with us in our mobile clinic. But when she went into labor, because we don't have a 24-hour service in Jawadhi, she went to the local PHC where she was also registered in Namyambet. And she had eclampsia, so they referred her to Odugatur. But Odugatur is a place which is quite far for her. She was not familiar with the place. She was afraid to go there, so she went home, died at home, and her child is right now being supported by the department. So all three, one patient where geographic access was a problem, the other one was very close to the PHC, but then because of migrant labor, she was not registered, and there were issues in the government about taking her. And this lady registered with us, but again, no services in the night. So this is the background with which we are sort of basing all our services, trying to decrease maternal mortality in Jawadhi. And of course, in between, COVID happened, so we had to sort of focus a little bit on the pandemic. But then still the main focus now is in establishing a center for MCH care in Jawadhi. So again, very briefly and quickly, for somebody who's not been to this area, Jawadhi itself, it's part of the Eastern Ghats. Size-wise, it's about 2,500 square kilometers. It's home to a tribal population of about 60,000 tribal people and another 20,000 non-tribal people. And the general health indices there are low, as well as the development indices. The terrain itself is a bit inaccessible because it's the Eastern Ghats and it's made up of little sections of hills and not a continuous range. Therefore, access becomes difficult. And on the whole, this tribe has been isolated there, so there's a little bit of mistrust and suspicion about working with outside people like us. And so there's a lot of building of relationships which has to be done before we can actually work with the community. In total, there are 294 villages and hamlets in Tiruvannamalai district and another 94 in Vellore district. Administratively, the government has divided it into these two regions. Other than CMC, there are actually 5 primary healthcare centers, but only 2 actually in the hills. The other 3 are serving the hills, but they are in the plains. Then there are sub-centers, but they don't work. There are some other NGOs which work here. The Red Cross and SRM from Chennai comes here and does some clinics and goes. There are many research excuse me, projects from other colleges like VIT and RINE. The whole area has 1 veterinary clinic. And for this entire population of about 400 hamlets, there are only 5 higher secondary schools, and they are all situated in that same place, Jamna Mathur, which is the sort of capital city of Jawadhi. So very quickly, some health indicators. We don't have very recent health data because our survey data is not complete. We've not been very successful in getting good data because of the migration of the people, and we are only now cleaning up our data to analyze. So if you look at this, you can see compared to Tamil Nadu in India, in 2007 when we did our first survey, 2012 when we did our second big survey, and now we have only small survey data. Jawadhi actually fares quite badly when you think of it as being part of Tamil Nadu, where the health system is supposed to be quite good. But the immunization rates and the other things I'm talking about below here are all current. So even now, completed immunization is less than 30%, and about 50% of the women are still delivering at home. Even though they are almost 90% of antenatal women register in a PHC, delivery actually happens at home because there's no transport to get them to hospital on time. And other indices also like education, employment, and all the other health development indicators are relatively low in this place. Like many other tribal regions, alcoholism is a problem, and in surveys which we did recently, we found that 54% of adult males in this region are hazardous drinkers. And I put it here because whatever programs we implement in this region, we have to keep in mind that we have to address substance abuse first. Otherwise, the women are not able to access our services if the men are not if the men are drunk. Some more data, a little more recent from 2015, the crude birth rate was 28.7, the death rate and the infant mortality rate, as you can see, is much worse off in Jawadhi compared to India. Some other data about child nutrition, which is now what we are focusing on, because we found in the pandemic that 2 things happened. One is education really slipped. Children who were supposed to be in the beginning of the pandemic, if a child was, for example, in grade 3, now 2 years later, because 2 years the schools have been closed, the child is supposed to be in grade 5, eligible to go to grade 5. But when we looked at their academic level using the ACER tool, we found that the child who was in grade 3 at the beginning of the pandemic has now slid down to grade 2 or grade 1. Children are not able to form alphabets. A child in grade 8 is still spelling out words and reading. So academics slipped. The other thing that slipped was child nutrition, because midday meal stopped. No schools, no midday meal. So children who were borderline became malnutrition, and children who are already malnourished slid down further. So this is some data. It is old. We are currently weighing children now in our night schools, and that data I'll be able to share with you maybe in a month's time. But already to start off with, these were the levels, with 60% wasting and 63% stunting, which is a reflection of acute and chronic malnutrition. And anemia, micronutrient deficiency. This is gross nutrition deficiency and micronutrient deficiency. We found that among tribal children, anemia is quite high. 35% of adolescent girls in the region are adolescent children in the region are anemic, as compared to 17% of the non-tribal children. And if you look at the medical causes of mortality here, for maternal mortality, it's mostly things which we'll expect in a geographically difficult area like eclampsia, sepsis, PPH, and underlying anemia, which is compounding all this. And in children, it is mainly infectious disease still, because immunization is low. There are outbreaks of disease and perinatal deaths. In adults, most of the women MCH problems, tuberculosis is quite rampant here. We found that cancer deaths are common here because people are not getting to hospital on time. And the commonest cause of death among young adults is road traffic accidents, usually due to the influence of alcohol. And these are some of the social causes which I already spoke about for mortality. So my presentation is actually like focusing on this area. So this was our response to it. So to improve access to healthcare, which seems to be the biggest problem here. And the second thing is, like I said, because of the little bit of distrust between the people in the hills and the rest of the community, health-seeking behavior is not common with the allopathic system. They have their own indigenous system of health, which they go to regularly, but very often it's not, meaning it doesn't help. And the other big area we are looking at from the department is to address the social determinants of health. That is all our development programs which we are doing in Jawadhi, and substance abuse, which is underlying problem which we'll have to sort out if we have to improve health or development in this area in any way. So I think some of you, I'm sure definitely Ruth has visited the center. This is our center in Jawadhi in a village called Veerapnur. This is my colleague Anu Alexander who's here. And we have a hospital here which we are running 6 days a week, but it's only in the daytime because we don't have a facility for staying. And as many of the admin in the FOV UK know, we are in the process of buying this land, a 4-acre piece of land from the Don Bosco Tribal Development Society. So that is in that again. It became delayed because of COVID and the pandemic closing all the government offices. But we are pursuing that again now. So these are the services which are offered in the center. There is a day clinic which runs every day, like I said, and the patients who come are usually general morbidity patients, chronic diseases, patients who have chronic disease cards who come for refill of medicines, antenatal and postnatal care, immunization, obstetrics, and pediatrics. We also have fixed clinic schedules for which I'll show you in a minute, and specialty clinics also which run regularly. The mobile services or the outreach services, we have 58 clinic spots, but this caters to about 140 villages totally. And the services which we offer are again antenatal, postnatal, chronic disease management. Patients who are low risk are seen in the periphery itself and don't come to the hospital at all. And home visits, health education also happen via the mobile. So this is just a little picture of the referral system which we've established. This system was established during the Dan Mission project from 2013 onwards. So if you can see here, these health workers here, 10 of them are actually supported by FOV UK, another 10 from Australia and 2 from the Model Village project. So they are our grassroots level workers. In addition to that, we have another 59 school teachers from the Don Bosco CMC collaboration. So they work on the ground. They refer patients to us. They might refer patients directly to the mobile clinic. They sometimes refer directly to Veerapnur clinic also. In the mobile clinic, they are seen by an intern or a resident, occasionally a consultant, and can be referred to Veerapnur or referred sometimes directly to Chad also. In Veerapnur, it's always a resident or a consultant because sometimes we get fairly sick patients there. So we don't post interns in Veerapnur clinic. And from Veerapnur, patients can get referred to CMC and to Chad. And ultimately, patients can access care in CMC also. Like Dr. Dayalan was saying, there are lots of patients who come very sick and run really huge bills from Jawadhi who land up in CMC. Very often, almost the whole bill is written off. Because these people don't have cash with them. They might have land, like agricultural land, or they don't have cash. So a lot of their bills is actually written off from the main hospital. This is just another picture of our referral system. This is our health worker measuring a child at home for our nutrition program. The lady in the green sari is a PHN, a public health nurse. They wear this color uniform, and this is a health aide doing a home visit here, immunization here. This is in the Veerapuram clinic. This is Dr. Titus, who's an orthopedic surgeon who came for the ortho clinic. This is Chad, excuse me, OPD, and this is of course CMC. So this is just a pictorial representation of the referral, where this at one end where the people are looked after in their home by the health workers, and this is CMC, the other end of the spectrum in our referral system. Another big component of our work is health education. Like I said, we are trying to build a relationship with the community and increase their knowledge about what allopathic medicine can do, so that health seeking is better from their side. And this happens regularly on a regular basis. Right now, all our health education is focusing on COVID and trying to improve vaccination acceptance in the hills, which is actually much less than what it is in the plains. Very briefly about the development activities. So these are the main areas of focus. In education, we have 59 schools which we run along with Don Bosco. We have a coaching class system for higher education for students. And the FOV UK has to date supported 9 students who, 2 of whom have graduated. I have a separate slide for that. And various other education in schools like life skills education. The Model Village program, we are planning to start a new village this year. We would have started last year, but because of the pandemic, we couldn't start. We are currently working with 3 villages. We do a lot of work with the forest department about afforestation and environmental protection, and a lot of work with the children. The summer camps have been suspended because of the pandemic, but the children's parliaments we are planning to start next month. The night schools itself, we only started last month. In July, 1st of July, we restarted the night schools. And our partners, the Don Bosco Tribal Development Center is by far our biggest partner because most of our work is done with them. We also work very closely with the government, and now especially with the vaccination programs, we are working with the government and other NGOs like the Forest Department, like the SFR, the Society for Forest Development, and other NGOs in that area. And of course, the Friends of Vellore, who support us in almost all the development work and a lot of the clinical work in Jawadhi. So just a slide about the scholarship program. FOV UK has supported 9 students, 7 girls and 2 boys, out of which 7 students have actually enrolled in for nursing and 2 for X-ray technician. 2 students have actually completed their studies and have joined work. 2 students will actually join this year, and the rest of them are still in their student period. Health workers are, and almost the entire services are actually dependent on the health workers' work in the area. During the pandemic, we had stopped home visits. We've restarted it now. So essentially what they do is they spend a lot of time on surveys, collecting health information from us, for us. They do a lot of work towards maternal and child health. A lot of NCDs are managed in the area itself by the health workers. They have BP apparatuses, they have equipment with them, which they take with them when they go to the village and monitor and refer patients from there. And now, like I said, a lot of work is being spent working along with the government, arranging for vaccination motivation camps and ensuring that vaccination happens in all the villages. So our future plans are still towards establishing a 24-hour hospital in Jawadhi. We really hope that we'll be able to get the land by the end of this year and start construction next year. If we can actually do this, it will really help us a lot in cutting down travel time, costs, and so on and so forth, and definitely help patients reach us, because in the night time there is no access to healthcare for them. If we have a hospital in the hills, then we'll be able to widen our service area also. Geographically, what we are reaching now is limited by our travel time. Just a brief slide about what is already there. We have in the clinic, we have special clinics. Every Tuesday is the substance abuse clinic, and once a month psychiatric clinic. Every 4th Wednesday is a high-risk obstetric clinic. Our obstetric day is actually quite busy. About 90 to 110 patients come on an obstetric day. Immunization happens on every 2nd and 4th Thursday. And we have other services like cancer screening, palliative care, Optal, ENT, and OT. Sorry, that is my last slide. I should apologize. I had another 2 slides, but I'm using a different device because my computer refused to log on in the beginning. My other 2 slides were on the pandemic. Ruth, do I have time to talk for another 2 minutes?
Yes, you've got 5 more minutes.
Oh, okay. So, so the pandemic itself in Jawadhi, the first wave, there were hardly any cases in Jawadhi because most of the people were living in the hills and had not gone back, and the government had prevented people who were people from leaving cities. There was no transport. Then, when the government allowed migrant laborers to return, there were patients who returned to Jawadhi along being COVID positive. But the government did a very good job, a really excellent job in isolating and quarantining people. And there was no indigenous spread in the first wave. We didn't have a single patient who got the disease from Jawadhi itself. And there were no deaths. In the second wave, unfortunately, COVID was really rampant. There were a large number of deaths and a large number of patients. And this time, the government did not set up any isolation centers. Most patients had to go down to Tiruvannamalai to the government hospital, and they were not willing to go there because of the isolation and the quarantine. So the deaths were also large. And the other thing is the testing in Jawadhi itself, the results were taking time to come. So if a patient was tested a particular day, that it will be only 4 days after that the result came. So many patients died within those 4 days and were buried or cremated before the result came. So after that, when the government tried to quarantine the family members, the family was very resistant. So on the whole, the systems didn't work very well. Right now, there are hardly any positives in the hills. People have started going out for migrant labor again, but predominantly people are still remaining in Jawadhi itself. And from CMC side, we started vaccinating in Jawadhi, but then the block medical officer who I work with quite closely, he requested us to concentrate on motivating patients, because somehow I think we have quite a good relationship with the people there. So we are able to motivate them much more than the government is able to. So when we motivate, people are coming to take vaccination. So we've sort of reached an understanding. We motivate patients for vaccination and the government vaccinates. So that's what we're working on right now. I think I'll stop there, and I'm happy to answer any questions.
Thank you so much, Anu. It was fascinating to hear your presentation. I was really struck how you started with 3 women who'd died in childbirth, and how that was the foundation for Dr. Ida Scudder, who started the CMC in the first place. So yeah, that really struck me, and it's devastating to hear that they are dying in childbirth. Chicha had a question. She just said, given that you haven't got the residential clinic yet, is it a priority to improve training and support for professional care for home delivery? Because I know you have some nurses living in the hills and health workers. Could you comment on that?
Yes, actually the government doesn't allow home delivery, so we cannot have a training program training people for home delivery. We encourage all patients to deliver in the hospital. But having said that, our health workers are being trained, but we encourage them not to attempt a home delivery at all, to try and get them to hospital as early as possible. This tribe actually doesn't have traditional dyes. Like a lot of tribes like Orissa and all, there'll be a dye or a birth attendant who's a locally trained person, like in the village, who will attend to deliveries. This tribe doesn't have that type of a it's only the mother or the mother-in-law who's usually there. So previously what Chad did is our pitchus, that is the part-time community of the workers from the village, they're traditional dyes who were trained by the department to conduct deliveries. But this tribe doesn't have that type of a people. So if at all we train, it'll have to be our health workers. And currently our health workers are girls who have studied up to grade 8 or grade 10 and have no medical knowledge. So we'll have to train people who have studied at least some A&M or some basic type of a medical thing. And the government does not allow home deliveries. So we are not focusing on training people on home deliveries right now.
Yeah, I can see. Okay. Prima has a question. She says, are there any opportunities for you to work with the local church in Jawadhi? Are there any churches in Jawadhi?
Yes. The National Missionary Service has churches in many villages in Jawadhi, and we do work with them. In fact, they have hostels for girls. We provide healthcare for them. We also work very closely with the Catholic groups which are there. That is the Don Bosco Tribal Development Society. Then the Deebam Hostel, which is the Salesian Sisters. The Salesian Sisters. They have a hostel and a school for girls. There is no. It's the NMS and the Salesians whom we work with in terms of religious groups. Plus, we also work with a lot of other groups who run schools and hostels. The CSI church itself is not there. The NMS is there, which runs services for the Protestant community.
Thank you. And what about family planning? Do you give advice to women in the hills on family planning?
We do give advice. Acceptance is low, but considering that their infant mortality is a little bit high, I myself hesitate sometimes a little bit because they do have high infant mortality. And the second thing is, other than tubectomies, which is a permanent method, there is no other method which is being offered there. Corporates, because of the high rate of sexually transmitted diseases in the hills, syphilis is about 15%. The corporates are not really recommended by our OG doctors. So we definitely recommend for people who have completed family to go in for some permanent method, but we don't push too much. The growth rate in this community is also not very large, not like the rest of India.
And how specifically can we be praying for you and your work in the Jawadhi Hills? What would you like us to pray about?
I would really think that our acceptance in this community is something which we'd like prayers on. We are quite an alien group of people for them, like, because see, we come from, many of us are not even from Tamil Nadu. Like, luckily, I am a Tamil speaker from Tamil Nadu who understands the local language and the dialect. But many of our doctors and nurses are from different areas. So the acceptance is still a little bit low. Our customs are different. The way we dress is different. Our God is different. Everything is different for them. So they hesitate to approach us. And we see this more and more when we work in the villages, not in the clinic, because in the clinic, they are actually seeking us. But when we go into the villages, we find, so that is one thing. And the second thing is I would like to request for prayers for the land to be bought. We are facing so many obstacles from the government. Every time we think we've reached somewhere, like there is some new problem which props up. Because our services, both our medical services and our development services, are so dependent on us actually having a facility there. So that is, I would think, our biggest prayer request right now. If God can just help us buy this land and remove all the obstacles from the local government, the senior government officials are easy to deal with. It's the local government which is a bit difficult.
That's really helpful. We will be praying for you specifically for those things. And I have one last question here, was whether, so of the students that we funded, 2 have now completed their studies. Are you able to encourage them to go back to the Jawadhi Hills and to motivate other young people to follow a similar course of study?
If you look at the team which is working in Jawadhi now, out of our 5 public health nurses, 2 are tribal, who study through the scholarship program. The person who sits in our front desk, that is Prabhu, his name is Prabhu. He is from Jawadhi. The ANM who is in the clinic, Mala, who studied in Sitlingi, is also from Jawadhi. So we try and employ people back there, and they are a big source of support for us, because they not only motivate the local people, but they also make them see that it is possible for them to study. And like, the general perception is that if you study in a government school or if you study in Jawadhi, you're not going to get into any good courses. But these people are examples that they can actually get into good courses, hold good jobs. So they do a lot of motivation for us. Also, our acceptance in the community is vastly improved by having them with us. So yes, they do motivate the local students to join for higher courses.
That's amazing. It's wonderful to see how your team is is growing and including more and more people from the Jawadhi Hills.
Ruth, can I just have a point of clarification more than a question? Anu, we were under the impression, I was not aware that acquiring this land was a problem. We were under the impression that we were in discussion with Don Bosco, the Catholic organization, the brothers, and we were going to be getting, or they were, part of their land was going to be used for this project. Is that not the case?
That is the case right now, sir. About 5 years now, we've rented out that land. The rent is also not a large amount. It's a sort of a small amount. But now from their side, they would like us to, if we want to continue using that land, they would like us to buy it. And from our side, we found that our administrators have said that we cannot invest in the land unless it is owned by CMC. We are planning a large, meaning we are planning to have a hospital there, and we are planning to have quarters. That's a lot of investment. So unless we are sure the land is going to be with us for some time, that's a lot of money to invest into that. So we would prefer to buy the land or take it on a long lease, like 99 years or something like that. So the Don Bosco Foundation is willing to sell us the land. The amount, what is going to cost, everything has been talked with their provincial and our director, and everything is settled. But what has happened is, being tribal land, there is a lot of formalities which have to be, it's in a reserve forest and it's a tribal land. And the Supreme Court in 2013 passed a law saying that nobody can buy tribal land other than a tribal. But being a NGO, like CMC and Don Bosco NGOs, it is possible to legally buy the land. But then there are lots of hoops we have to jump through before we can get down to it. And that is what is happening now. And doesn't help that the administrative office is in Tiruvannamalai. It's not in Jawadhi, it's not in Vellore, so we have to make that. And that's why I was requesting press, because once you go to the government office in Tiruvannamalai, we find that the officer is not there. Then the day he's there, his secretary is not there. And meaning something's always happening like that. So if all that can be sort of facilitated, then we'll be able to do some real work.
Okay, thank you.
Anu, can I ask you a few questions? And firstly, I just want to thank you for it's just remarkable to see the work you're doing there. It's brilliant. It's very sad that there is still so much deprivation and trouble and such high maternal, child and crude death rates. In your opinion, what are the low-hanging fruit is my first question in terms of what can be addressed to try and cut down on some of that. Obviously, the maternal and child health, you alluded to a bit, but the crude death rate I'd be interested in. And the second question is how much, we learn in community health, and obviously you're a very senior person within the field now, you must be aware of how we engage with the community itself to see what they want, and do they recognize that these are problems that they want you to address?
So in terms of low-hanging fruit, I think if we do something which is not very sophisticated in terms of medicine, of course very expensive, but if we can even establish a center there which is open in the night, a lot of maternal mortality can actually be sorted out if they just reach a medical facility in time. I would think that we don't need any sophisticated medicine. We don't even need a theater right now. If we can just sort of provide basic services for stabilization and referral, then that itself will decrease mortality a lot.
So along those lines, your own units, Anu, you said you have one unit there, but there are 5 PHCs. So I'm assuming that those PHCs are functioning presumably at least during the day. And do they have any nighttime facility, or is that sort of abandoned? And how do they compare with the numbers the numbers that you're seeing in your unit?
Toman, actually only 2 of those facilities are in the hills. That is Namiyampet and Jamna Mattu. The other 3 are catering to tribal patients, but they are actually down. People have to go down to reach them. And in the nighttime, though there is a doctor on call, the doctor is not there. It's not even a nurse who's there, it's a compounder. A compounder is somebody who sort of deals with medicines and dispenses medicine, like a pharmacist. So many of the patients have told us that when they go there, there's nobody there to take care of them. We have a very good relationship with the government, and we work quite closely with them, especially after COVID started. But and in many of the ways, the team on the ground is very, very, very enthusiastic, very eager to work with young people. But there are so few of them that they spend the whole day doing COVID vaccination, traveling in the hills, that it's difficult for them to do. Meaning, if you can understand, the motivation to do night duty is not there, because there's no senior people there. They are afraid to take in community health department, we have so many seniors that nobody's afraid to see a patient because you can call for help. Like if you have a sick labor patient.
So do you think there's scope for you to use their facility while you wait for your bottlenecks to be sorted, especially with the fact that you're trying to sort out the land and then establish your nighttime unit and so on. So while you're waiting for that, is it possible for you to sort of use their structure and facilitate, care at night using the PHC system, and sort of, is that a possibility, or is that a totally unacceptable thing to do?
We've discussed it with them. The thing is, if you go to the PHC in the night, there is a board there which has the name of the duty doctor and all. So first we have to, meaning it's going to look bad on them, because then they have to accept that there is no duty doctor. Because when we went to the collector and asked about immunization, for example, saying immunization rates are very low, please give us permission to immunize. The collector said that his record shows that immunization rates are very high. So like that, in theory, there is a duty doctor there. So why will a CMC doctor be, I have done deliveries in the PHC. And while it was happening, the doctor came. We after a lot of negotiation with them, we are now stocking anti-snake venom in the PHC, because we're having deaths due to snake bite. So we are working with them on small, meaning we don't want to, get on the wrong side or antagonize. But as of now, using their facility is not possible for us.
Yeah, I think Chitra is talking about not being convinced about the nighttime facility, and I'd be interested to know what the actual solutions you would have to some of those higher end mortality that you alluded to, and it'd be interesting to sort of break that down and see if that's the primary thing. So I don't think we have enough information here to make any judgments on that, but I'm sure you've thought about it quite deeply.
Can I just add, I don't think the nighttime facility doesn't just affect the nighttime. Currently, CMC's time that they are allowed to be in the hills is very limited, because they have a long travel time and they have to be out before a certain time in the evening. So having a facility that allows staff to stay over would even allow them to run longer days rather than just be operational in the short hours in the middle of the day.
Yeah, it will cut down our travel time. It will allow us to have an evening OPD, which the people have been asking for, because right now we shut down at 4 o'clock. Because it's a reserve forest, we have to exit the check post by 6 p.m. So we have to leave at 4. So if we have a facility there, that means we can have the evening clinic, which people have been asking for. And MCH is just one component of the work. There are road traffic accidents, there are children with various illnesses, and all sorts of facilities, all sorts of services which we could provide. Only a small component, meaning maybe 50% of the component will be maternal health. Because the PHC also caters to all diseases, and if there's no doctor for MCH, there's no doctor for other things also. So,
I think all these questions are really minor in comparison to the amazing work you're doing. It's just so brilliant and so wide and covers such a huge ground, the training, the education, and everything else. So it's just really moving and impressive, Anu, that you're doing such a good job. So thank you.
Well, thank you so much.
Yes, and can I echo my thanks, Anu? We're so pleased that you're able to join us this morning and this afternoon for you. Yeah, really delighted that you could share the wonderful work that you are doing with us. So thank you.
Thank you, Ruth.
We'll now just move on to a brief presentation that I'm going to give, just giving you an update on Friends of Vellore UK and what on our projects. Okay, so our aims, we particularly at Friends of Vellore UK seek to support projects that promote the health and welfare of the poor and marginalised. That's why we love being involved with the work in the Jawadhi Hills and RUSA and the low cost effective care unit. We also coordinate prayer support and seek to raise the profile of CMC here in the UK. I'm the charity manager. I'm the only employee and I work 2 days a week reporting to the trustee board, which is chaired by Diane. Here's our financial summary for 2020. You can see that our income was 263,000. This was similar to the previous year, and both 2019 and 2020 were significantly higher than the previous years. The 2 years prior to that saw income levels of around 150,000. So we're very grateful for the increased giving, which last year was partly due to your response to the impact of COVID at CMC. We were able to send in 2020 nearly 46,000 to CMC to help them cover their COVID costs, in addition to the 160,000 that we gave for non-COVID projects. And we were also able to support some of CMC's affiliated mission hospitals. We sent donor-directed gifts of 18,000 to Baptist Christian Hospital Tejpur in Assam, that's in northeast India, and 5,000 to Ashakiran Hospital in Odisha in East India. Our running costs of 27,000 were covered by the income from our investments. So we didn't have to take any money off donations. I now want to share with you the results of this year's COVID appeal. We had an amazing response to our 2021 COVID appeal. To date, we've raised 221,000, which is a fantastic sum. We've allocated 220,000 already, which has gone to CMC and 7 of its associated mission hospitals to help them cover costs incurred due to the COVID pandemic. The funds are being used for oxygen generators, equipment to treat COVID patients, patient care costs and expansion of ICU facilities. We've recently been approached by Karagiri Hospital, who have asked for us to help them raise funds to purchase an oxygen generator plant. This hospital was set up originally to serve leprosy patients from CMC, but now serves the northern end of Vellore and the surrounding rural population. So we're hoping that we can raise some more funds to enable us to send them a grant also. In addition to this, we had some independent fundraisers here in the UK who raised money for CMC and other mission hospitals. This generated an additional £68,000 of funds, which have and will be transferred by us to the recipient hospitals. I'll move on to our regular ongoing projects. The person-to-person scheme is used to provide small targeted grants of approximately £100 to help pay the hospital bill for specific patients who are unable to afford their treatment. Donors who give to this scheme receive reports directly from CMC on which patients their donation has helped. And for the past few years, we've sent 40,000 in support of this scheme, and we hope to be able to continue to send a similar sum each year. However, we would love more donors to the scheme to be able to continue our support at that level. You could consider sending someone a birthday or Christmas gift by way of making a donation to the scheme. I can provide cards to that effect. Our projects at RUSA, Rural Unit of Health and Social Affairs, include 4 elderly welfare centres, the Patchakilly Children's Place Centre, and for the past 3 years we've been funding a project that's screening for developmental delay in children and training parents and other caregivers in caring for those children. We've also funded a fashion design course to enable local women to earn an income. Low cost effective care unit works in the slums of Vellore. Here we seed funded the posts of 3 community health workers and a driver. They're reaching out to many who wouldn't otherwise access the services of CMC. So these care workers are providing health education and healthcare for expectant mothers, children, the elderly and disabled, those with chronic diseases and acute health problems. They run clinics and identify those with disease or illness who need transferring onto the main hospital. And in 2019, their pioneering posts were absorbed into CMC's regular budget, which meant that the remaining 2 years of our funding could go towards funding 2 additional community health workers, so enlarging the scope of this work. As Anu has said, we are funding 7 students from the Jawadhi Hills in their training in nursing and other allied health courses. These students come from families where the parents have had little or no schooling and they depend on farming and manual labour for their livelihood. And we're also funding 10 health workers who are young people from the Jawadhi Hills who CMC have trained to work as health aides. They visit people in their homes, offering health advice and making referrals where necessary. And it's a key role because they are local tribal people themselves. The villagers trust them and are more likely to seek out healthcare from them. Many of you will know that Dr. Abraham George, who studied medicine at CMC, is running the London Marathon this year for us to raise funds for the Jawadhi Hills. He would love you to sponsor him. And when I send around details about the recording after this meeting, I'll include that link. Years ago, we provided seed funding to start the post of missions network consultant at CMC, which was later incorporated into their budget and led to the formation of a missions department. This seeks to help smaller mission hospitals across India raising their profile and sharing resources and expertise. For the last 3 years, we've supported the new post of mission desk coordinator. Magdalene, who fills this role, provides assistance to missionaries and mission hospital staff from across India who need to travel to CMC for specialist healthcare that they can't get locally. And 40,000 has recently been given to start a mission hospitals fund. We're going to use this money to support to enable smaller mission hospitals in India who are affiliated to CMC to build chatrams. These are buildings that provide basic accommodation for people to stay in when they've travelled a long way for treatment and can't afford to stay elsewhere. And this year we've allocated several grants to mission hospitals affiliated to CMC through our COVID appeal to cover costs from COVID. Those raised directly through FOV UK have totaled 160,000, and then we've had another 39,000 through others raising funds. We've also been involved in a 3-year project to help fund a mobile ophthalmic unit at CMC. We're partnering with Friends of Vellore Australia and in the US for this, which means we could spread the cost between the 3 of us. So our portion was 30,000 and we gave that in 3 £10,000 instalments over 3 years. This clinic will screen and treat patients with diabetic retinopathy as well as other eye disease in rural areas around Vellore. Diabetic retinopathy is a blinding complication of uncontrolled diabetes, but it can be prevented by regular screening and timely intervention. So this unit will address issues of poor access and follow-up. It will make screening accessible to much larger numbers and enable treatment in the field for those who need it. Each year we send funds to support the palliative home care team. Our grant covers fuel costs, medication and basic supplies to enable home visits to those in the last stages of their life. And a legacy we received in 2019 has enabled a new service to begin at Chittor campus. In addition to the trustee approved grants, we also facilitate alumni and supporters giving to other projects and batch funds at CMC. Various gifts have been sent this year. And this slide summarises the CMC grants we've made and expect to make in 2021. I've talked about most of these areas already. But there are lots of ways you can support CMC. For the details on any of our projects or on how to get involved, please go to our website. Did you know that whenever you shop using Amazon, you could be raising funds for us for free? Just use Amazon Smile link and choose Friends of Vellore as your chosen charity. And I just want to end by commenting on this picture in my slide. It's a photo of staff from CMC's low cost effective care unit meeting with people living in the urban communities they serve to find out what improvements they want to see in their local area. Whenever I have the chance to visit CMC and see the staff reaching out to care for the poor and needy, I am humbled by their compassionate service and desire to love others in response to the love, unconditional love that they have received from God. It's a privilege to partner with them, and I hope you too are inspired by the work they are doing. Are there any questions? No, well, as there are no questions and we are pretty much at the end of our time, I'll hand over to Diane to close our meeting.
Okay, it's just a quick thank you. Big thank you to Thurman for being involved with this and to Ruth for organizing it. Thank you for all the supporters attending, and most of all, thank you for your generosity with our recent appeals and for your prayers throughout the year. Thank you all, and we hope to see you again in a year's time, but we will keep you updated and we'll be in touch even before the next supporters meeting. Thanks to everyone. Thank you. Goodbye.